Good afternoon, all. I'm Adam Myers, the co-director of the Health and the Public Interest Program with Dr. Adrian Fu Berman, who's also on this Zoom. And we're pleased to have Jennifer Oliva from Georgetown and also Indiana University to talk to us about the new war on drugs. But she'll be introduced momentarily by Sasha, our student moderator today. Before we begin, I'd like to say that the Health and the Public Interest Program is a program that emphasizes basically the non-medical issues that affect public health, including policy and economics and social disparities, et cetera. So this fits right into that formula, and we're again happy to have Jennifer. I also wanted to remind everyone that we're reaching the end of this semester's seminar series. In a couple of weeks, you'll have the opportunity later to rejoin us next fall in a reformulated seminar series on a little bit different platform, but once a month and kind of hitting on these same issues. So watch out for that, and we're happy to be able to continue this despite the closure of the underlying graduate program for this current series. So, with that, I'll turn it over to Sasha, and she'll tell us about today's speaker.
Thank you, Dr. Myers, and thank you so much to everyone for taking time out of their day to join this week's seminar. I'm super excited to welcome Dr. Oliva or Professor Oliva to this week's seminar. Just for a little bit of a background, Jennifer Oliva is a professor of law and Val Nolan Faculty Fellow at Indiana University's Maurer School of Law. Her research and teaching interests include health law and policy, privacy law, evidence, torts, and complex litigation. She's a United States Army veteran who serves as a research scholar at Georgetown Law's O'Neill Institute for National and Global Health Law and a senior scholar with the UCSF UC Law Consortium on Law, Science, and Health Policy. She also serves on the Johns Hopkins University UCSF Opioid Industry Documents Archive, National Advisory Committee, and the National Pain Advocacy Center Science and Policy Advisory Council. She is also an elected member of the American Law Institute. Professor Oliva is an honors graduate of Georgetown University Law Center, where she was a public interest law scholar and executive notes and comments editor of the Georgetown Law Journal. Prior to attending law school, Professor Oliva earned her master's degree from the University of Oxford and an undergraduate degree from the United States Military Academy. Professor Oliva has earned numerous awards for her scholarship, teaching, and service. Most recently, Professor Oliva earned the Indiana University Maurer School of Law Trustees Teaching Award and Indiana University Maurer School of Law BLSA Outstanding Interactive Professor Award. One interesting fact about Professor Oliva is that she was a military police officer in the U.S. Army for 5 years before attending law school, and it was that experience policing soldiers returning from deployment suffering from PTSD and SUD that furthered her desire to become a healthcare lawyer and focus her expertise on behavior health issues, SUD, and other stigmatized mental health conditions. And then another little fun fact is that her current hobby is aggressively biking along the Beeline in Bloomington with her toddler, whose nickname is Peanut Butter in tow, which I think is super cute. And then, yeah, without further ado, please join me in welcoming Professor Oliva to this week's seminar.
Thank you so much for that exceptionally kind introduction. My voice is a little bit hoarse here, and it's Peanut Butter's fault. She's brought the petri dish that is daycare home with her, so I apologize for that. Let me get my slides up, and if anyone has any trouble seeing them, please let me know. How does that look to you guys? All right, great, great, great. Awesome. Okay, so today I'm going to be talking about the new war on drugs. And I just wanted to say from the start, I'm so thrilled to be here at Georgetown, back in my old stomping grounds, to give this talk. The talk is based largely around a paper that I co-authored with Professor Talib El-Sabbahy, who's at Wayne State, and was published in the Virginia Law Review about 18 months ago. And what we basically argue is the war on drugs isn't over. It's just been retooled, recalibrated, and reframed. So here's my agenda, my roadmap. I'm going to start this lecture talking about the old drug war, its origins, its defining characteristics, and in our view, why it's a failure. Then we'll move on to what we call in the paper the new drug war, which I'll analyze through three lenses: enhanced surveillance, enhanced criminalization, and civil penalties, and ongoing obstacles to treatment harm reduction in this space. My spoiler for this talk is right here on the first slide. We're going to argue, folks, it's the same old drug war, that the rhetoric has changed. We're sort of framing a lot of this stuff in public health narratives now, but the underlying punitive substance remains largely the same. Okay, so we contend that the old drug war is best described by four characteristics. It's punitive, it's racist, it's costly, and it's been ineffective. And let's take each of those seriously. We believe they're not rhetorical flourishes to make ourselves look nice for the law review reviewers, but they're documented facts. And they really matter in this talk because the new drug war inherits all four of these flaws. Okay, to begin, the old drug war was uncompromisingly punitive. It was built on a single simplistic theory. If you increase the supply of criminal punishment, you decrease the supply of drugs. In other words, arrest enough people, impose enough mandatory minimums, build enough prisons, and eventually the problem will dissipate. The results, however, point in the opposite direction. The United States is the leading per capita incarcerator in the world. We constitute less than 5% of the global population, but account for nearly 25% of the world's incarcerated people. Drug arrests are the leading cause of arrest in this country, and the vast majority are for simple possession or personal drug use and not for drug trafficking. We're not getting drug kingpins here. It's not what we're talking about. And this is the architecture of our war on drugs. It's been enormously costly and hasn't worked, and it's devastated communities of color with a disproportion that we'll argue is neither accidental nor subtle. Okay, speaking of which, our next argument, which is, I think, relatively uncontroversial, is that the old drug war was racist. Michelle Alexander, in her block-breaking new book, The New Jim Crow, made the definitive case that mass incarceration functions as a contemporary racial caste system. Our paper sits squarely in that tradition, and it's worth spending a moment on why Alexander's framework matters so much to us. Her core argument is that the war on drugs didn't just produce racially disparate outcomes sort of accidentally. It was designed for that outcome. It created a legal mechanism for stripping predominantly Black and brown men of civil and political rights in the aftermath of the civil rights movement. Once you're labeled a felon, you can be legally discriminated against in employment, housing, voting, jury service, and the list goes on. The formal markers of Jim Crow were gone, but the functional subordination was not. What our paper adds to that framework is an insistence that the system is ongoing and that it's actively adapting. The public health rhetoric of the new drug war isn't evidence that we've moved beyond the new Jim Crow. It's evidence that the caste system has gotten better at masquerading its motives. And let's go to our statistics. The numbers are awfully stark here, folks. It's consistent and well documented in the research literature that Americans use and sell drugs at similar rates across racial and ethnic lines. That stated, see right on the screen here, Black Americans, who represent only 13.4% of the US population, account for 26% of individuals arrested for drug offenses in this country. They're nearly 6 times as likely as their white counterparts to be incarcerated for a drug-related offense. This is not a disparity that can be explained by differential behavior. It's a disparity that is explained by differential enforcement. The drug war targets communities of color selectively, systematically, and with devastating effect. So here's one of the most important structural points of our paper. The classification of drugs as dangerous or benign in this country has never been based on sound pharmacological science. Our government has a habit of characterizing drugs as good or bad, not based on their chemical profiles, but on the groups associated with using the drugs. Drugs associated with white, middle-class users tend to get medicalized, while drugs associated with people of color tend to get criminalized. There is a well-documented historical pattern here that has repeated itself with remarkable consistency from at least the 19th century until today. Let me try to make that point with pictures. Take a look at these images. Cocaine marketed as a toothache cure for white children. Laudanum, which is liquid opium, sold over the counter and famously in the Sears and Roebuck catalog for decades for a litany of maladies, including so-called female complaints. And we have here heroin marketed as a cost suppressant in major newspapers. In the late 19th century, the most prevalent opioid users in the United States were white middle-class women who became addicted to morphine that was prescribed to them by their physicians. This is the context in which our first drug prohibition laws were written. And here's what those laws targeted: not morphine, not laudanum, not the cocaine and the medications for the kids. They targeted opium smoking, a method of opium delivery which was associated at the time with Chinese immigrant men. The opium trade and the wave of Chinese immigrants to the American West in the mid 19th century set the stage for the country's first drug prohibition campaign. Chinese workers brought over to build the Transcontinental Railroad were visible, economically vulnerable, and racially targeted. Opium smoking, practiced in the Chinese communities, became a flashpoint for nativist anxiety. The substance itself was not the concern. The people associated with this particular use of this particular drug were the issue. This image brings us to the first wave of American drug prohibition, and it's worth dwelling on the specific rhetoric that drove it because it's going to sound familiar and we're going to see it over and over again. The campaign to criminalize opium smoking in the 1870s was not primarily framed as a public health measure. It was framed as a protection campaign, specifically the protection of white women, as you can see in this image, from Chinese immigrant men. The narrative was lurid and deliberate. Opium dens, it was claimed, were spaces where Chinese men lured white women into seduction, addiction, and moral ruin. Newspapers ran sensational stories. Politicians amplified the panic. The threat to white female virtue was the engine that drove prohibition legislation. San Francisco's 1875 ordinance criminalized opium dens specifically. It did not target morphine. It did not target laudanum, both of which were consumed primarily by white women and remain perfectly legal. The Chinese Exclusion Act, the Federal Chinese Exclusion Act, followed quickly thereafter in 1882. Okay. Well, cannabis is perhaps one of the most instructive case studies in racially motivated drug prohibition. Harry Anslinger, who was the inaugural director of the then called Federal Bureau of Narcotics, which we can characterize as the predecessor of today's Drug Enforcement Administration, launched a decades-long moral panic against cannabis in the 1930s. The drug had already been stigmatized through its association with Mexican immigrants, and Anslinger weaponized that association to keep his agency in business after the end of alcohol prohibition. He had been a prohibition officer during alcohol prohibition. This quote speaks for itself. I'm not going to repeat it, but we just talked about this narrative. This is the ideological foundation upon which cannabis prohibition in the United States was built. Anslinger ran the Narcotics Bureau for 32 years. He quashed medical efforts to treat substance use disorder as a disease. He manufactured statistics. He shaped legislation. The Controlled Substance Act, which still governs drug scheduling today, vests final scheduling authority not in the FDA or another federal health agency, but in the DEA, a law enforcement agency. Okay. This newspaper article brings the historical arc right up to the moment of Nixon declaring, the formal war on drugs. By the late 1960s, heroin use in Washington, D.C., a majority black city, was being covered in the press as a crisis of black urban communities. The framing was not sympathetic, folks. It was criminogenic. It associated black men, urban poverty, and heroin into a single kind of threatening image. As we'll see in the next slide, the Nixon campaign was actively working at the time to forge precisely that association in the public mind, to make black and heroin synonymous so that criminalizing one became a socially acceptable proxy for targeting the other. Okay, and again, in 71, Nixon famously declared drugs public enemy number one and launched our modern war on drugs. That war was characterized in the popular press as a public health and public safety initiative. But in 1994, journalist Dan Baum interviewed John Ehrlichman. Ehrlichman had served as Nixon's White House counsel and chief domestic advisor. And here's what he said during his interview, and I'm going to quote this one. The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about drugs? Of course we did. In other words, the war on drugs was, at least since its modern inception, a political weapon wielded against Black Americans and other political dissidents. So, punitive, racist, now let's address costly and ineffective, because those two flaws are deeply intertwined. Okay. The United States has spent over $1 trillion on drug interdiction over the last 4 or 5 decades. Federal, state, and local governments spend an estimated $47.9 billion a year on drug enforcement, which is an extraordinary figure. And what have we bought with all those billions and trillions of dollars? Record-setting overdose deaths. The illicit market today is not smaller than it was in 1970. It's larger, more volatile, and more deadly than ever. We've not arrested our way to a safer drug supply. We have, if anything, made it a more dangerous phenomenon. And I'll come back to that in a minute, called the law of prohibition. Okay. So that's the old drug war. Has anything changed? Well, policymakers across the spectrum, in all fairness, have jettisoned some of their more punitive rhetoric and adopted this kind of more public health framing when discussing drug use and drug misuse. They say we can't arrest our way out of the problem, and that's become a bipartisan refrain. Congress passed the Comprehensive Addiction and Recovery Act in 2016 and the Support Act in 2018, both of which are significant legislation that includes some real public health provisions. And we acknowledge that in our paper and acknowledge that some of this marks genuine progress. The formal recognition of harm reduction as a federal priority, for example, was real and meaningful. But we urge caution. New policy proposals may be dressed up frequently in public health clothing, while an insidious retrenchment of the punitive approach walks in lockstep beside them. I don't know if any of you know Leo Beletsky, a good friend of mine. He's a fairly famous drug policy scholar. And whenever he gives a talk, he says it's always 1 step forward, 2 steps back. So he sort of always cautions us not to get too excited when there's legislation that we believe is moving in the public health direction. Okay. So our paper examines this phenomenon through 3 categories of laws and policies: enhanced surveillance, enhanced criminalization and civil penalties, and ongoing obstacles to treatment and harm reduction. Let me take each of these in turn and keep them in the sort of modern new drug war space. So category 1, enhanced surveillance. The old drug war was built on a surveillance state. There's no question about it. We have wiretapping, GPS tracking, financial monitoring, aerial surveillance, you name it. But the new drug war has doubled down on that tradition with new and powerful tools like prescription drug monitoring programs, which are turbocharged by artificial intelligence. Under the old drug war, surveillance of patients and providers was already burdensome. Folks who were taking medications for opioid use disorder, for example, were subject to daily check-ins. Methadone administration was like this. Mandatory random drug testing and pill counts, mandatory counseling, and extensive federal oversight. The basic posture of the old drug war was if you use controlled substances, you're a suspect until proven otherwise. The new drug war has taken that framework and dramatically expanded it. We still have all of these old drug war things in place, and some of them have been enhanced. But in addition, you can see here we have new CDC guidelines that function as prescribing mandates, new state surveillance legislation, these prescription drug monitoring programs that I'm going to talk about extensively in a moment that are powered by AI and software, and increased surveillance of non-opioid prescription medications. Okay. So prescription drug monitoring programs. This is an all-time favorite of mine. So I don't know what you guys know about PDMPs. They're state-operated electronic databases. And what they do is collect, store, and analyze information about the prescribing and dispensing of controlled substances and other drugs we'll call, for purposes of this presentation, drugs of concern. A handful of states had rudimentary paper-based versions of these systems decades ago. But what started happening around 2000 was an explosion in state PDMPs. 27 states stood up new PDMPs in the first decade of this century alone, supported by more than $60 million from the DOJ and DEA. So basically, DOJ and DEA injected a bunch of funding into the states to sort of like massage and manipulate them into standing up these prescription drug programs. That was extremely effective. Today, 50 states, DC, Guam, Puerto Rico, and the Northern Mariana Islands have operational PDMPs. So we have 54 of them. Federal government also continues to aggressively fund and expand them. In 2022 alone, DOJ awarded nearly $30 million to the states for PDMP enhancement. The critical point that I want to make right at the front end, and I'll repeat this a couple times, so forgive me, is that PDMPs were developed as law enforcement tools. The DOJ has said that explicitly in numerous reports, describing them as valuable instruments for drug diversion investigations. They were not developed for a clinical purpose or primarily as public health surveillance. So let's keep that in mind. Okay. The new drug wars PDMPs are not your grandmother's old PDMPs. The evolution has been dramatic. Originally, most systems monitored only Schedule II drugs, okay, the highest risk drugs on the federal schedule that are legal to prescribe. Today, most PDMPs monitor Schedule 2 through 5 drugs, so all licit scheduled drugs. And as I already mentioned, this amorphous category called drugs of concern. The state of Nebraska uses its PDMP to monitor all prescriptions issued in the state of Nebraska. More importantly, these systems are no longer passive paper systems. I don't know if you guys are probably too young out there, but if anybody's ever heard of carbon triplet paper, used to like write the prescription, out, and the doctor would keep one. You'd take one to the pharmacy, the pharmacist would keep one, and then send it into the state PDMP agency. That's not at all what we're doing here anymore. These are real-time electronic databases powered by AI software that automatically pushes red flag alerts to law enforcement and state regulatory boards. And they increasingly also, by the way, share data across state lines, so this information isn't staying in intrastate anymore. We've effectively created a de facto national prescription surveillance network. Okay. So I want to talk about this drugs of concern a little bit. This is a category that deserves special attention, even if you do believe that the opioid crisis is over, because it illustrates how surveillance creep works. You ask yourself a question: what are these PDMPs going to be continued to use for if we have nipped the opioid crisis in the bud? And some of the things they've been used for already is scheduling drugs at the state level that are not on the federal schedule, that are targets like mifepristone, misoprostol, the abortion medication drugs, targeting things that are on the federal schedule with heightened scrutiny, like Schedule III testosterone, because it's used in gender-affirming care in states that have banned that or strictly reduce it, and then adding things to drugs as the category of drugs of concern for stigmatized conditions that folks want to target. So I think this is something that we should keep our eyes on. The list of these drugs expands annually. They're usually easily added through a simple regulatory procedure, and there doesn't appear to be any clear limiting principle. They don't have to be habit forming or any of this other kind of stuff. Something to keep your eyes on. Automated reporting, as I already mentioned, at the heart of the drug war surveillance, the new drug war surveillance apparatus are these like red flags and this auto reporting. These PDMP software algorithms are designed to identify patients, prescribers, and dispensers that the algorithm characterizes as high risk, okay? And then once that's identified by the software program, it automatically generates a report, like I said, that it gets shoved out to various enforcement authorities, law enforcement, pharmacy boards, physician regulatory boards, etc. How is high risk determined? Well, the algorithms are proprietary, so we don't know for sure, but we do know that they mine through patient prescribing histories, the patient's demographics, and other data points to generate this risk number. Here's the problem. We also know that they incorporate a litany of other outside databases that are problematic, things like criminal history, trauma history, medical cannabis dispensing records. In the United States, criminal records function as a proxy for race from like a data science perspective, and women are more likely to have reported sexual abuse and trauma to their medical providers. So the algorithms are replicating and embedding existing social disparities and inequities. These red flags can trigger a federal criminal investigation. It can end a prescriber's career with a raid and a federal registration suspension. And it also just functions day to day as a legitimate, as a chilling agent for prescribing to patients in genuine pain and with other severe healthcare conditions. And as I mentioned to you, these are no longer interstate operating entities. Federal law enforcement has pushed hard for these federal interconnected networks, but don't take my word for it. The PDMP Interconnect brags about how interconnected these things are right on its own website. I just literally cut and pasted this. 52 of the 54 PDMPs are interconnected, as you can see here. They brag about 92 million patient encounters per month, saving prescribers time, saving physicians time, et cetera, et cetera. Look, you only have to spend 2.2 to 5 minutes per patient. You don't have to go look through their extensive medical history. You can just rely on the PDMP and the risk score that it's generating. This is all quite problematic. Okay. So what does the evidence say about whether this surveillance reduces overdose deaths? We're not complaining about it just because we're bitter and we don't like surveillance. Here's a sample study. There's many of these, but this is a good longitudinal study that looks at, it's a meta-analysis, and it's a 2022 meta-analysis. And what they say here is that PDMP use, I'll just use their words, has no relationship with overdose mortality. So standing them up in states and expanding them had no associated positive impact on driving down overdose mortality, but they were associated with increased overdose mortality in various analyses. So you might ask yourself, why would that be? Well, this is the old school and it's well known. The answer is the iron law of prohibition. Surveillance-driven crackdowns on prescription opioids drove many patients away from regulated dosed pharmaceutical products and to the illicit market, dominated once by heroin and then quickly replaced by illicit fentanyl, which is 50 to 100 times more potent than heroin. So the iron law of prohibition says the more intensely you enforce supply control, the more potent and dangerous the remaining supply becomes. This isn't new. We saw it during alcohol prohibition when Americans switched from beer to bathtub gin and other spirits that were easier to transport and disguise. And the same dynamic happened here with opioids. And you can just look at the CDC visual chart yourself. As I told you, around 2000, these systems started standing up. We now have 54 across the country, but overdose deaths very sadly continue to escalate. And at least since 2013 have not been in any way, shape, or form dominated by prescription opioids. Okay, so we've talked about the AI-driven surveillance of the new drug war. Let's now talk about enhanced and expanded criminalization. We argue in the paper that the new drug war expanded the punitive toolkit in at least 4 notable ways. There's rise and increase of drug-induced homicide laws, fentanyl-related product scheduling and rescheduling, I'll call upscheduling, enhanced civil and criminal penalties, and those that specifically targeted pregnant people I want to talk about today, and the widespread demonization and rejection of progressive prosecutors. Okay, so drug-induced homicides. I don't know if you guys know about these DIH laws. They're sometimes called death by distribution laws. Their purpose is to make it easier for prosecutors to charge someone with homicide, first-degree murder, or a manslaughter charge when a person shares drugs with someone else who accidentally fatally overdoses on those drugs that were supplied by the defendant. Many of these laws eliminate the mens rea requirement, so they're more akin to strict liability criminal laws. They're not new. Several states have these laws in the books that date back to the Reagan era, but they have proliferated dramatically during the new drug war. At least 10 jurisdictions enacted new or expanded DH laws between 2012 and 2019. And even more tragically, DIH prosecutions increased by more than 500% in just 6 years, from 109 on the books in 2012 to 696 on the books in 2018. The racial dynamics of DIH enforcement are exactly what you predict if you believe anything that I've been saying so far in this presentation. This slide draws from the Drug Policy Alliance data. Black defendants convicted of drug-induced homicides receive a median sentence of 10 years. Asian defendants, 13.5 years, whereas their white counterparts generally receive sentences around 6 years for the exact same legal violation. Worse yet, prosecutors have disproportionately brought DIH charges in cases where the victim is white and the defendant is a person of color. So that's the most likely scenario where you're going to see this charge. DIH laws also bother us as harm reductionists because they undermine Good Samaritan laws, right? These are the statutes that offer legal immunity to people who call 911 during overdose to get help for someone. Good Samaritan protections typically cover at least simple possession drug charges in most jurisdictions. Almost none of them cover DIH charges. So basically what we've done is we've said, hey, call in. We're not going to charge you with simple possession. You're not going to get a judge pick up a drug charge, but you can pick up and may in fact and do sometimes pick up a homicide charge. Okay. So research confirms the harsh effect of these laws on individuals who use drugs. People with close ties to someone who's been charged with a DIH are more likely to say they would not call 911 if they witness an overdose. And that's in the research. So the deterrent effect of these laws operates not against drug distribution, but against overdose rescue. Okay. Fentanyl, scheduling enough scheduling. Okay. So here's I'm being bipartisan in my complaints about people today, as you can see. In 2018, and again in response to this ever shape-shifting opioid crisis, the DEA placed all unscheduled fentanyl-related substances on Schedule 1. So he deemed them illicit. Okay. Congress subsequently passed the HALT Fentanyl Act with bipartisan support to make this permanent. The problem, scheduling fentanyl analogs into Schedule 1 doesn't do anything to reduce illicit fentanyl availability. It simply enhances the criminal penalties that attach to possession and distribution, and that disproportionately falls on Black and brown communities, who are now the populations most devastated by the current version of the opioid overdose crisis. Colorado, probably known to many as a fairly progressive state on drug use, unfortunately followed a very similar path very recently. The state enacted a law in 2020 that made possession of up to 4 grams of Schedule 1 and Schedule 2 drugs, which would obviously include fentanyl, a misdemeanor rather than a felony. And so they reduced the criminal penalties that attach to that simple possession charge. At the time the law was enacted, one of the bill's sponsors, State Representative Leslie Herod, who's a Democrat, said, and I quote, "We can't incarcerate ourselves out of addiction." Thereafter, however, the law was scapegoated as the primary contributor to the surge in illicit opioid-related overdose deaths in the state. So the Colorado legislature decided to crack down. In 2022, they passed the Fentanyl Accountability and Prevention Bill, a law that re-felonized simple fentanyl possession. That same rep, Leslie Herod, who had sponsored a 2020 Decriminalization Act, was a primary sponsor just 2 years later on the refelonization law, which frankly sailed through the Colorado legislature with virtually zero opposition. On civil penalties, the drug war's collateral consequences are vast and well documented, and virtually none of this has been rolled back during the new drug war. Public housing exclusions for cannabis use stand, notwithstanding, that's cannabis is legal for at least some purposes in 3/4 of the states. And perhaps most urgently, we've seen a real uptick, especially since Dobbs was decided, the criminalizing and civilly surveilling pregnant people who use drugs. More than 1,700 women were arrested between 1973 and 2020 on charges where being pregnant was a necessary element of the crime. So a non-pregnant person doing the same behavior could not have been arrested in those jurisdictions. The overwhelming majority of them involved pregnancy drug use, and wait for it, the use of legally prescribed drugs like buprenorphine that were prescribed to these women by their physicians to treat substance use disorder. States have also increasingly decided to define prenatal substance use as child abuse, child neglect, or chemical endangerment of a child, and their healthcare providers are mandated reporters. So the pregnant people most affected by these policies are predictably low-income women and women of color, which are the same populations that have the least access to substance use disorder treatment. Okay. Backlash against the progressive prosecutors. So the new drug war's punitive reentrenchment isn't limited to what's happening in state legislators or by these regulatory agencies that I've been discussing. It's also played out pretty dramatically at the ballot box through a well-funded, nationally coordinated backlash against progressive prosecutors. The clearest example here is on my screen, which is Chesa Boudin. Boudin was elected the San Francisco District Attorney in 2019 as part of a national wave of progressive prosecutors who pledged to seek alternatives to incarceration, try to end the racist war on drugs, and campaign to hold police officers more accountable. He implemented fairly significant diversion programs, declined to prosecute low-level simple possession cases in the city, and explicitly rejected the punitive drug war framework. In June of 2022, he was recalled by a 60-40 margin after a campaign that capitalized on fears of rising crime, and a campaign that was, frankly, and this is public information, not my opinion, heavily bankrolled by Bay Area tech and real estate interests who outspent his side by more than two to one. But Boudin was not alone. Similar recall and removal campaigns targeted progressive prosecutors in Los Angeles, Chicago, Philadelphia, and St. Louis. The pattern was consistent. Prosecutors who attempted to operationalize a public health approach to drug use, who declined to prosecute these low-level possession offenses, who diverted people to treatment for substance use disorder rather than incarcerating them, faced organized, heavily financed opposition that framed harm reduction as lawlessness. And to us, this is the new drug war's political infrastructure, and it's hostile to genuine health reform. Okay, you guys are almost done with me. My last category here is the obstacles to treatment and harm reduction, and I'm going to focus on three things. This is where I think the gaps are. And these two things kind of fall into two categories. And those two categories have robust, unambiguous evidence of effectiveness. Harm reduction programs, such as syringe service programs and overdose prevention centers, talk about in a minute. And of course, the gold standard medication treatment for opioid use disorder, specifically methadone and buprenorphine. And the new drug war has built substantial and ongoing obstacles to access to both. So syringe services programs, for those who are not in the know, although I think most people on here probably do know, these programs provide sterile syringes, infectious disease screening and treatment, naloxone, connections and social services, and a whole host of other programs and treatments for people who use injection drugs. They've been studied for nearly 3 or 4 decades. And the evidence is pretty overwhelmingly positive. SSPs has been shown to reduce HIV transmission by up to 50%. They decrease needle sharing. They promote safe needle disposal. And really critically, they make people 5 more times more likely to enter drug treatment voluntarily who have access to these services. Now, federal law has admittedly prohibited the use of federal funds for SSP for decades, but not because they didn't work, but because they were seen as incompatible with the war on drugs. It was a sort of facilitating drug use narrative. In 1998, then HHS Secretary under President Bill Clinton, Donna Shalala, presented evidence after a long period of study that SSPs reduce HIV and do not increase illicit drug use. But at the time, drug czar Barry McCaffrey, who is a West Point grad, much like myself, killed the proposal. Okay, he killed the proposal, and that year that he killed the proposal, 1998, 17,047 Americans died from AIDS-related complications. Black Americans, who are 13% of the population at the time, accounted for 49% of those deaths. Today, SSPs are under renewed attack, and in the places where you will be perhaps most surprised. In 2021, West Virginia, which has among the highest overdose and infectious rates diseases in the country, enacted laws to severely restrict SSPs in that state. I'm sitting here talking to you from Bloomington, Indiana, as you heard earlier. Scott County, Indiana, in my home state, which was ground zero to a catastrophic injection drug use related HIV outbreak in 2015. That was resolved by an SSP that was stood up in the emergency by then Governor Mike Pence. The county commission of Scott County actually voted to end that successful program in 2021. Well, even worse, it did so against the recommendations of the Indiana State Health Commissioner, the United States Surgeon General at the time, and both county and former county sheriffs from the county. And their argument was that SSPs enable dangerous behavior, facilitate illicit drug use. Okay, let's talk about the OPCs. So overdose prevention centers, they have a lot of names. They're sometimes called supervised consumption sites, safe consumption sites. These are facilities where people can use drugs under medical and peer supervision, receive drug testing, sterile equipment, naloxone, and referrals to treatment. They've operated legally in Canada, Europe, and Australia since the 1980s, and there's a really strong evidence base for their efficacy as well. Many folks say, I can't prove this one way or the other, but it's frequently said that there's never been a single reported overdose fatality that has occurred in an OPC. But more easier to prove is that they reduce public drug use, for sure. They reduce needle litter. And they also are strongly associated with reducing crime in surrounding areas and increasing treatment uptake. The United States is the last developed democracy in the world to continue to absolutely prohibit and outlaw these programs. Here you see on my slide, Philadelphia made a long-standing effort to open a facility called Safe House, which was a privately funded OPC. And when they did that, they were met with a federal lawsuit under the Controlled Substance Act's crack house provision, saying you're operating a crack house. Unfortunately, that case went to the Third Circuit after Safe House was successful in the Eastern District of Pennsylvania, and the Third Circuit held that operation of facility indeed violated the Controlled Substance Act. The Biden DOJ thereafter quietly signaled it would evaluate Safe House and try to work with the facility to find a compromise. But as we document in our paper, a bunch of Republican senators wrote a letter to the Biden administration arguing that this was radical, illegal, and dangerous, and the talks collapsed. New York City actually has opened the first active 2 OPCs starting in 2021. Both are privately funded and operated by a nonprofit called On Point NYC. They've intervened and documented that they've intervened in hundreds and hundreds of potentially fatal overdoses, but they're under constant threat from the U.S. Attorney from the Southern District of New York, who intermittently threatens to sue them and shut them down. In related news, and so that I don't want to limit this to Philadelphia and New York City, Pennsylvania recently passed a statewide ban on OPCs statewide. Philadelphia City Council also banned them in 9 of the 10 city districts. And perhaps most surprisingly, California Governor Newsom vetoed an OPC legalization bill that had been overwhelmingly passed by the California State Legislature. So the pattern repeats itself over and over again here. Evidence-based, proven, gold standard, evidence-based harm reduction is sacrificed on the altar of the old drug war ideology. So literal, I promise you guys, last thing here, and we'll open it to questions. So OUD treatment access, how's that improved? On medication treatment, let me just say that the effectiveness of methadone and buprenorphine, I don't think is any longer a matter of scientific debate. There's a consensus that has been established through large systematic studies and randomized controlled trials that demonstrate that these medications reduce fatal overdose deaths, improve treatment retention, decrease HIV transmission, reduce criminal activity, and have lowered neonatal abstinence syndrome rates. The National Academies of Science, Engineering, and Medicine have endorsed them unequivocally as a gold standard treatment in this context. And yet, less than 15% of adults with opioid use disorder in the United States receives these medications. Less than 15%. The barriers are partly structural, cost, insurance coverage, provider availability are huge problems, but they are substantially legal, right? Federal law has historically required most opioid treatment program patients to travel to a clinic daily to receive methadone administration. Buprenorphine prescribers face these layered federal licensing requirements and fairly extreme DEA surveillance. The system is designed around diversion prevention, not patient access to the medications. And I also want to note here that the racial inequities are quite severe. Of 13.4 million buprenorphine prescriptions that were issued between 2012 and 2015, 95% of them went to white patients. Okay. So where's the last thing I want to say, the COVID-19 pandemic also created a natural experiment for us here. SAMHSA issued waivers that allowed take-home supplies of OUD medications and telehealth prescribing. And treatment access substantially increased, and this is well documented. Overdose mortality also decreased during the pandemic. The evidence for keeping these reforms, therefore, was quite strong. But what did the Biden DEA do in March of 2023? It issued rules proposing to roll them back. I will say here, this is a little bit of a happy story to conclude on because the agency received nearly 40,000 public comments, and virtually all of them were in opposition to its proposal to roll back this access loosening. The DA is temporarily retreats and comes back with stuff every 6 months here. So it's a space to watch because this fight is ongoing. All right. So where does this leave us? The war on people who use drugs is far from over, folks. It has been rebranded. It's been given a public health veneer, but at its core, it continues to prioritize surveillance, punishment, and the illusion of a drug-free society over the interventions that we know save lives. What would a genuine public health approach look like? Well, it would look like dramatically expanding access to methadone and buprenorphine without bureaucratic gatekeeping. It would look like funding and not shuttering, harm reduction programs like syringe services programs. It would look like permitting overdose prevention centers to operate legally. It would look like repealing drug-induced homicide laws that deter 911 calls. And it would look like transferring scheduling and other important authority over controlled substances from the DA to an agency with scientific health expertise. None of these things require waiting for perfect consensus because the evidence already supports them. What they require is the political will to stop treating drug use as a moral failing and start treating it as the public health challenge that it is, with the full suite of public health tools at our disposal. Thank you for your time, and I'm happy to take your questions.
All right, thank you so much, Professor Oliva. That was such an incredible and informative lecture. I know that we all kind of greatly appreciate hearing things like this. And so now we're just going to open it up to questions. We're first going to go with people from my cohort first from the HAPI program, and then we can kind of open up questions to the general audience. But I would like to kick off asking you a question first while my colleagues kind of brainstorm their own questions or type it out in the chat. But this question kind of came to me throughout your lecture, first with kind of the imagery that you showed at the beginning of your lecture with, for instance, the cocaine as like a toothache remedy, and kind of seeing that evolve over the timeline of the old war on drugs and the new war on drugs. And I think that my question for you kind of is communication based and how public health practitioners can kind of utilize, social media or what is kind of surrounding us today communication wise in overcoming a lot of these issues, because right at the end of your lecture, you kind of stated the need for increased funding and accessibility, but there's so many challenges and there's so much improvement that needs to be made with that. And I think that kind of overcoming that political weaponization and everything like that is just so imperative and important in finding solutions to this. So how much do you think that public health practitioners kind of in their communication styles and conducting campaigns and spreading awareness can have an impact in eventually enacting policy and legislation that can really help this out, if you think that it could have an impact at all?
Well, I definitely think that it can have an impact. I mean, look, the public health infrastructure, since we wrote the paper in such a short period of time, has really been decimated in this country. So I don't want to pick on those folks too much. And not only has it been decimated at the county and state level, it's been decimated at, in Atlanta, Georgia, at the CDC. And the folks who are left with boots on the ground are fighting so many. I mean, I'll tell you what, I have a toddler, peanut butter, as you know, everybody heard about, I'll squeeze in peanut butter any chance I get here. But it's terrible. I've talked to a pediatrician quite frequently because, those little germ rascals have to go to the doctor quite a bit in the first couple of years of life. And his biggest struggle here in Bloomington, Indiana, a blue dot in a red state, is trying to convince vaccine skeptical parents to have their children vaccinated. I just think the public health workforce is up against resource intense and communication intense battles now on like 50 fronts. It's just incredibly, incredibly challenging and difficult time. So I don't want to come out swinging from them. I will say I think there's a bunch of stuff we can learn about how we handled SciComm during COVID that could have been better or improved. And I think that folks have learned those lessons or are in the process of learning. Folks like you are in the process of learning those lessons. In order to accomplish what you're saying, the governments, state governments, county governments, and federal government has to stop funding the rhetoric, right, that leads people to believe in these sort of simplistic stories about drug use and has to sort of fund, SciComm that promotes evidence-based solutions. The other thing that I run into all the time here in my primary sort of group of folks that I talk to and research with, like I said, are these pregnant women who have been punished badly for seeking treatment for opioid use disorder over the last several years. And, they all, when you talk to them, have heard this lesson. You're just swapping one drug for another and have, this has been drilled into them. So I would just say that my experience is that, yes, this can be done, but we have to have the political will and resources put in place to actually drive the sort of positive SciComm that we need here to convince people to do the right thing and to support policies that will help us reduce drug overdose deaths.
Awesome. Thank you. That really helps and answers my question so
Good
well.
luck to you, ma'am.
For sure. Okay, our next question is from my colleague Giraud. He said, "Thanks for this amazing presentation, Professor Oliva. Given your work on the opioid crisis and pharmaceutical accountability, how do you see the legal system balancing innovation incentives for drug development with the need to prevent corporate practices that contribute to public health harms? And where do you think current policy frameworks are still falling short?"
That's like such a great question. I don't know if that person has investigated some of my public comments before here, but let me just say what I've said in the past about this, and I think it's really important. So I appreciate the platform. One of the biggest problems with the response to the opioid epidemic, beyond what I spoke about today, which was all this sort of like punitive crackdown, iron law prohibition stuff, which drove us in this really dangerous underground markets, was that the government's response was limited to, and the litigation response is limited to coming up with a caricaturish like villain or villains like the Sacklers and targeting just one substance, these are prescription opioids, right? Instead of looking at the underlying root causes of drug use, problematic drug use in the United States, and the structural problems that facilitate pharmaceutical malfeasance for prescription drugs that have been approved at the federal level, right? So what I mean by that is, everybody who was involved in opioids has to pay some settlement money or were sued, and the FDA cracked down on opioids, and the CDC cracked down on opioids, and the states started surveilling opioids, and Hulu and Netflix. I can't turn on a show anymore where like the underlying villain or thing is somebody that was involved in opioid distributing or opioid prescribing. So this is like very sincerely, deeply embedded in American culture. But guess what didn't happen? We didn't change the marketing rules that pertain to folks who market prescription drugs in the United States. We didn't change or crack down on the detailing rules that pertain to pharmaceutical companies in the United States. We didn't change the revolving door things that allow someone to walk out of the DEA right into a distributor, drug distributors, and treat them with kid gloves the entire time they're regulating those people. We didn't change the closing door stuff at the FDA. Some of the states that received the largest amount of settlement money that were hit the hardest have been it's been proven that they had the information to take action against opioid manufacturers way earlier than they did. And they didn't. And West Virginia and Kentucky are examples of this. Reporters had to fight for years up and down the United States, including the Washington Post, just to get access to the litigation materials that judges placed under seal to protect corporate interests. So we could have known a lot of this stuff decades in advance. None of those kinds of things have changed. You go look at like the major litigation that's going on right now with health insurers, these coverage algorithms and these other big things. The same exact thing's happening. Judges are placing their behavior under protective orders. It takes decades to find out, and none of these structural reforms involving the CDC, the FDA, the DEA, state health departments have happened. Nothing structural and rampant. Everything has been the Sacklers are the bad guys. Let's do some Hulu and Netflix, and let's target opioids with all of this enhanced law and policy. But that leaves everything else out to dry. So I do think it's really important that we think really hard about that narrative that is deeply embedded in the American psyche right now, and why it's unfortunate in the moment that we weren't able to say, look, there are big time structural problems here that need to be addressed. And I also think that all of that relates to what I already talked about, which is why, we don't see what you're saying, this psychom rhetoric that's evidence-based, why we don't see enhanced funding for things that we know work and are effective and reduce overdose mortality in the United States.
Thank you so much. I want to give my colleagues just a minute. We do have a couple more questions from the general public, but if nobody from my cohort has any questions right now, I will move on to a couple from the general audience. Miss Betsy Schneck asked, I think that in Portugal, drug misuse is treated as a medical problem and not a criminal problem. How well is that working?
Yeah, I mean, Portugal is, I don't, it's not a perfect system. Okay. There's definitely issues. So, nothing's perfect, but them moving to the medical model has proven successful, and it's provided sort of a role model for the rest of the world. I mean, they actually have gone beyond their internal system. And if any of you all in the program are interested, they will train people, and you can actually go to Portugal and sit with the commission and watch how this works. And they've been very good about reaching out to American researchers, but researchers across the globe and folks who are interested in public health policy. So I very much encourage you to go and see the system. And by the way, do what I always recommend that students do. Go in very skeptical, right? It's not perfect, but it is really worth comparing what Portugal's been doing since over the last, oh my gosh, 20 years now, to what the United States has done over the last 20 years, and look at I wish I had a slide here with me. I have so many slides on this, and just look at the overdose mortality rates and the dramatic difference in Portugal versus other European states, and of course, the United States.
Thank you. And then we have our next question from Mr. John Grogan. A few years ago, I heard about Portugal adopt. Oh, I think this is a similar kind of question, but I'll just go ahead and read it. A few years ago, I heard about Portugal adopting a new strategy for harm reduction. Is Portugal the gold standard? Where are the global best practices?
Yeah, again, like I said, Portugal's held up for this because it kind of systematically does this on simple possession. But there's other countries to look to as well. Like Switzerland, for example, people may be shocked to hear this. Does allows people to take heroin for maintenance that have OUD, and has a real success story to be told on that. As I already mentioned here as well, there are a ton of other industrialized democracies across the globe that very fund and support and have legalized these other harm reduction interventions like SSPs, OPCs, and those sort of things. So there are a ton of other models that you can look at across the globe in various different pockets of these things that have done experiments and tried. That we wouldn't know that these things work the way that they did when they're criminalized in the United States unless they have been tried in other places and researched. So there are a ton of interesting, good models out there that the United States could choose to adopt if it wanted to. And there's been a fairly substantial amount of research about a variety of these things. So I would encourage people that are interested in Portugal not only to remain interested in Portugal, but to look beyond Portugal to other novel treatment interventions that have been stood up in other jurisdictions.
Okay, thank you. And then Dr. Myers, you wanted to ask a question?
I just want to make a announcement or comment, which is that, well, first of all, Jennifer, thanks so much for a powerful presentation today, and we'll have lots of time for more questions. I wanted to point out that next week we'll have Rick Mountcastle, who is a litigation lawyer from the early days of the opioid crisis on till today, and he's going to talk about sort of the history of that and what the successes and failures in those litigations were. And believe me, there are some failures there, despite the big sums of money that we've all heard. The second thing is that if anybody out there, I know we have some students probably from the Addiction Policy and Practice program in the audience today, but Georgetown does have a program in addiction policy and practice. So if you're interested in it, please feel free to check it out on the web. And maybe Jenny, if you're listening, you could put the URL in the chat. So again, thank you, Jennifer, and I'll turn it back to our moderator.
Yeah, I think we have another question from the chat from Miss Campos. What do you think we can do on a personal level to contribute?
Yeah, I mean, phew, how much time do you have? So on a personal level, one of the most important things is to at this stuff is local. So at your local level, get involved. Like one of the things that's happened with syringe programs and other sort of harm reduction, just naloxone distribution and stuff, is the NIMBY stuff comes into play in a lot of these cases, right? So you could be very proactive in your community about educating your city council, educating your county commission on these kinds of things and what's evidence-based, and riling up your neighbors and friends, right, to support reforms in this area. And like I said, a ton of this stuff is local. And that is across the board in drugs. I mean, one of the things that you guys probably know for sure is the NIMBY stuff plays a huge role in whether a medical cannabis dispensary can be stood up or not. I mean, it's just across the board. It plays a huge role in what the county or city's homelessness policy is, which is super integrated and directly tied to sort of all of these criminalization results here. So what I would say is stay informed. If you guys want me to, I can send a list of various policy groups that sort of track legislation at the local and federal level. You guys probably already know that stuff, but to stay informed with your local groups and communities and monitor your state legislature and advocate for real reform resources and change in this arena so that we actually can help people live the lives that they deserve in this country.
Thank you so much. We really appreciate all of your insightful answers to these questions. I think that might be all of the questions that we have. If anyone wants to last minute unmute or raise your hand or put in the chat, but it looks like we've gotten everything answered. So Dr. Myers, Dr. Fuberman, if you had any last comments, I can go ahead and close it up.
Okay, just real quickly again, Jennifer, thanks so much for doing this. Thanks for your enthusiasm in agreeing to do this and following through with it. It's great to have speakers who jump at an opportunity to talk about something that they're passionate about. So wonderful to have you here today. And with that, I will turn it over back to Sasha and to close it out.
Yeah, just echoing Dr. Myers, thank you so much, Professor Oliva. Truly such an informational and such an interesting presentation. And we thank you so much for your time and for everybody's time, taking times out of their day to come view this lecture. I hope everyone has a great rest of your week, and we will see you for next week's seminar.
Thank you so much.
Thank you and take care, everyone.